Good evening, everyone. I take the pleasure of welcoming you all on behalf of Ratlam Society for a webinar today on perinatal awareness, a must for all obstetricians. For this, we have great speakers with us, along with Anupama ma'am, to chair this session. And for welcoming you all, I formally invite our president, Dr. Manisha Maheshwari ma'am.
Thank you, Dr. Neha. I bring greetings from Ratlam Society. We have gathered on the virtual platform after a long gap. It's my pleasure to welcome our guest faculty, Dr. Chinmay Rath from Hyderabad. She is presently chairperson, Foxy National Perinatology Committee. I warmly welcome Dr. Professor Anupama Dave Madam, Professor and Unit Head, MGM Medical College, Indore. I extend a hearty welcome to all the seniors and colleagues of Ratlam Society, as well as other society members who have joined us for today's meeting, which is having a very good topic of perinatal awareness, a must for all obstetrician. I would like to introduce Dr. Anupama Dave. Though she is a regular faculty in our society, I will quickly go through her CV. She is MS, MRCOG, DNB, FICOG, FICS, MNAMS, Professor Unit Head Department of OBGYN, MGM Medical College, Indore. At present working as Superintendent MTH COVID Hospital, Indore, organizing Scientific Committee Chairperson of just finished AICOG 2022, Indore, Present Secretary ISOPAB Indore Chapter, Past Secretary IMS Indore Chapter, Organizing Secretary MCCON 2015, BreastCon 2018 in Indore, Past President Indore Branch, a very active member. She is UG and PG teacher since last 27 years. Many awards to her credit, which includes recipient of Foxy Sun International Traveling Fellowship in 2016, received ICOG Foreign Travel Award in 2014, winner of prestigious Foxy Korean Award in 2013 for research work, Dr. D.S. Don Best Paper Award in AICOG 212 in Varanasi, winner of Dr. Amendranath Dan Award in Chennai AICOG in 2015, invited as faculty in AICOG since last 15 years. She is Master Trainer, Nodal Officer for Foxy EMOC Training, Master Trainer for IPAS, CAC Training, Common Cancer Screening Program, has many publications, including 45 national international journals. Welcome, Dr. Anupama. I would request you to please welcome and introduce our speaker, Dr. Chinmay Madam. Dr. Anupama. Are you there, madam?
I think her connection was a little weak thana. Maybe she'll join back.
Yeah. Till then, shall I introduce you, madam?
No problem, ma'am. It's informal. Kya bolna hai? We all know each other.
Welcome, madam. Dr. Chinmay has done her MS MRCOG UK, FIMSA FICOG. She is Director Resolution Fetal Medicine Center, Hyderabad. Lead Consultant Fetal Medicine, Yashoda Hospitals, Hyderabad. She is present Chairperson Foxy National Perinatology Committee from 2021 to 24. President SFM Telangana Chapter 2022-24, Treasurer OGSH 2018-22, Chairperson Fetal Medicine Committee OGSH 19-23, Fetal Medicine Foundation UK approved trainer in India, RCOG UK moderator for ERP MRCOG Part 2 exam, ICOG Foxy certification course, Center Head for Fetal Medicine Ian Donald ultrasound course. Wow, madam, so many feathers.
Okay, ma'am. I think Anupma ma'am is back online. Anupma madam.
Yes.
Welcome
thank
you,
Manisha. Thank you, Manisha. Can you hear me now?
Yes.
Thank you, Manisha, for introducing Dr. Chinmay for me. At the outset, first, I would like to thank the very dynamic president of ROGS, Dr. Manisha, and the dashing secretary, Dr. Neha Saraf, for inviting me to chair this session. And it is a privilege to have with us Dr. Chinmay Rath, who is an eminent maternal-fetal medicine specialist. You have already introduced her. To start the session, we as obstetricians consider the fetus the second patient. And so this is the reason why we are very much concerned for the safety of the fetus in utero. And to tell us more about this, about perinatal awareness, I invite Dr. Chinmay Rath.
Thank you. Thank you so much, madam. Actually, now that I know you are a faculty in Indore Medical College, let me tell you, I'm a near miss in Indore. I took my MS admission in Indore, MGM Medical College. But that was the time when there weren't many hostels. So people had to stay in paying guest accommodation. My father was not happy with that. And then when I got in Allahabad, he shifted me to Allahabad.
Ma'am, which year?
This was long time back. Because उस समय that ये क्या बोलते हैं, there was no direct train from Varanasi to Indore apart from Shipra. So we had to come to Bhopal and then take the bus. So he was not happy. So जैसे Allahabad में हुआ, he shifted me. This was in I think 2000 99 2000 वो time है. So anyway, that was Dr. Ratna Thakur was the HOD
Ratna
Thakur
Thakur
at that
ma'am
time,
was
because
our
I remember
HOD,
I had to
yes.
get it signed by her when I left my seat.
But I was there at that time in college.
I'm
But
sure.
somehow
I'm sure.
didn't know.
Yeah, we didn't know. So at the end, I've just learned that it's a small world and all the dots ultimately get connected somewhere or the other. So thank you very much, Manisha madam, for this invitation to speak in Ratlam. And I'm sure one day we'll meet physically. We have to do a program in Ratlam with the Perinatology Committee. As soon as it is feasible, we'll make that happen. So at the outset, the topic that we have taken is perinatal awareness. As madam has just said, my core area is fetal medicine, where I look mostly at the health of the fetus in utero. However, taking over as the chairperson of the perinatology committee, I've started working in an area where how can, we give the best to the mother in the perinatal period, because an obstetrician is in the line of fire if anything goes wrong in the perinatal period. And what is perinatal? The word perinatal means around birth. So it's something around birth. But if you look at the, definitions per se, you have an infant period, neonatal period, and a fetal period. But the perinatal period extends any time from 22 weeks of gestation till the 7 days of birth. So anything that goes wrong in any in this stage of pregnancy and after birth, we have to be responsible for that as obstetricians, and hence it is important for us to be aware of what can go wrong at this point. So Murphy's Law is something which, we keep on repeating every time. And as obstetricians, I think all of us are aware of this. Madam, the Purohit madam is here and she'll know that, whenever, if anything can go wrong, it will go wrong. So that is something which we all have to remember, that nothing is as easy as it looks. Everything takes longer than what you expect. And if anything can go wrong, it will go wrong, and it will go wrong at the worst possible moment. I'm sure all of you who prepared to stay here for this webinar this evening must be dreading from morning कि कोई ऐसी emergency नहीं आ जाए, कोई ऐसा चीज नहीं हो जाए कि हमको 6:30 बजे वो बुलावा आ जाए. And so those things do go wrong. But perinatal period is one such event where, you need to be aware. And this awareness will help you identify those risk factors. Timely identification of these risk factors can lead to proper management, and this can help in reducing the perinatal morbidity and mortality. Often we need multimodal alertness. I'll just come to what is multimodal alertness, but doing great obs and gynae also may not be enough sometimes in an obs and gynae practice. And that is the period of perinatology where it will tell you why you need to be aware of many things. So what can go wrong? Multimodal money, anything, anywhere. So when anything, anywhere, starting from the electric connection of your labor room to the, oxygen supply in the anesthesia, that is a completely lateral thinking what I'm doing. But if you come to the core people in perinatology, that is the mother and the fetus, you may have a sudden collapse of the mother. And that can happen to anybody in the labor room, like an amniotic fluid embolism or a peripartum cardiomyopathy. Yesterday, I was talking to my obstetric colleague, and she had a patient who had come to see her postnatally. She had delivered the twins after severe PIH, everything, and everything was fine. Baby stayed in ICU for a long time, went home, all good. She just thought this woman is looking very breathless. That also, when she was walking out in the corridor, she saw the lady sitting there. She said, "You're looking very breathless." Why don't, she said, yes, I'm feeling quite breathless since morning. She said, why don't you go and have an echo downstairs? They took her downstairs. By the time she reached downstairs, she was almost gasping. And then they got a 2D echo and the ejection fraction was 20. And she was like almost immediately ventilated. That was a case of peripartum cardiomyopathy. Just yesterday, I was talking to somebody. And this will just hit us which way we don't know. Suppose she was in the auto, suppose she was somewhere else, suppose we had not arranged that echo, anything could have gone wrong. So that alertness is very important. Altered behavior. We have these perinatal mental disorders nowadays, which we don't realize how significant they can be. New onset symptoms, SLE flares, perinatal infections. And in the baby, any stillbirth can happen for any reason. Birth asphyxia can happen for any reason, but every time it's the obstetrician who's blamed for that. Prematurity, undiagnosed anomaly, metabolic dysfunction in the baby because of genetic causes that will all manifest in the perinatal period. So these undiagnosed conditions in the mother, there are some medical problems. Many women, they come to their mother's house to deliver. India mein ye bahut acha tradition hai ki they'll have antenatal care somewhere completely and then they'll go to the mother's house to deliver. So this obstetrician who handles the woman in the perinatal period, some people might think, "Arey, ekdam pakka pakaya case hai, kuch bhi nahi hai, I just have to deliver." But you will not be aware if there are undiagnosed medical conditions in that lady. So that awareness is very important. Whenever you take a woman in the 8th or 9th month of pregnancy, you must make an effort to check everything else. Placental adherence is another thing which is going to become our nightmare with all these cesarean sections happening. So these are our red flags which we should be aware of. Perinatal issues have many stakeholders: the mother, baby, couple, family, obstetrician, neonatologist, hospitals, and society in general. We've had these sad incidents in our society. All of us are aware of these things, and everything that happens in the perinatal period. There is a huge burden for all the stakeholders. So we cannot neglect the fact that perinatal period is an extremely important period. Statistics say that more than 2/3 of newborn deaths occur within the first week of birth, and most of them occur within the first 24 hours of birth. So that baby which we are nurturing in utero can die in 75%. I mean, or 75% of those babies can die who die in the first week of birth. So the patient will still be our patient by then. So we need to be answerable when anything goes wrong, whether in the mother or in the fetus, because the obstetrician has been the longest caregiver. Somehow everybody starts looking at you as if you did something wrong. And even in terms of maternal deaths, almost 2/3 of the maternal deaths occur in the postnatal period, and a majority of them occur between the 3rd trimester and the first week of birth. So that inversion of perinatal antenatal care and all that is great. That is great in terms of screening for other problems. But when it comes to actual delivery of care, it is the perinatal period which is most important. So this is an example. 30-year-old lady, primary, full-term cesarean section done because of floating head, postdated by 2 days, unfavorable cervix, uneventful baby. You've delivered the baby, you're very happy. You've come over, you're watching a webinar or you're doing something, you're really happy. But after 1 hour, the patient was shifted to the ward, suddenly complained of chest pain, epigastric pain, and breathlessness, had a seizure, rolling of eyeballs in a few seconds. Now, all of you know that this can happen in theory, but God forbid if this happens actually to one of your patients. How ready are you to, immediately react? What is this? Is this gastritis? Is this impending eclampsia? Is this an epilepsy? Is this acute myocardial infarction, amniotic fluid? Is this just functional? Sometimes we feel like she's pareshan, so she'll behave like that. We have so many things to think about at that point. So in this case, the doctor was called, she gave injection pantoprazole. The complaint still continued. ICU registrar was called, examined the patient. The BP was on the lower side, shifted to ICU. In ICU, all supportive measures were taken, started oxygen, blood investigations, ECG leads, portable X-ray was done, 2D echo was done. And then finally, there was a suspicion of amniotic fluid embolism. And this amniotic fluid embolism, we all know this theoretically. It is a life-threatening complication. It can practically happen in any pregnancy. And as of yet, it is an unpreventable complication. You can't do anything. Doing a section is not going to save you from amniotic fluid embolism. Doing anything will not save you. So the point is identifying this problem and being ready to manage it. So if one of you is practicing in an area where you don't have access to a intensive care person or an X-ray person or somebody who can do a 2D echo immediately, then how safe are we in practicing? I'm not saying that you can't practice in smaller setups, but where is the justification that if the court asks you that you knew this was an unpreventable complication, why did you then deliver the woman in that circumstance? And when will that happen? We won't know, as we saw in the case recently in Rajasthan that happened. So this awareness is very important. You need to be careful about the predisposing factors. But if you look at that list of predisposing factors, which one can you actually avoid? There is none of them that you can avoid. So the only way that you can be safe is to have a high index of suspicion and to be having some backup for an intensive care if you need at any point. You may not have everything right there in your nursing home, but at least there should be somebody whom you can just call, and within 10 minutes, 15 minutes, that person can either be available or your patient can be safely shifted into that center. And this we all have to understand. If we don't have it, we have to make MOUs, start a group practice, or do whatever it takes, because if we are in a problem like that and there is a maternal mortality, unfortunately, then we have nowhere to explain that, okay, why did we do it in these circumstances? So the further management of that can go up to the level of requiring a ventilator, and then gradually, taking care of her coagulation status and everything, and then, making sure that she's okay. So that is not a core obstetric area of management. And we won't feel comfortable doing that. However good we are as clinicians, the moment there's something which goes to the heart and the lungs, we all start feeling shaky. So first and foremost important thing is, wherever you're doing obstetric practice, please have an intensive care backup. Because if nothing happened till now, we are lucky, we are good, but we can never guarantee that nothing will happen now. And we are no longer in that blanket of, trust and sort of safety that people will accept, oh, she's a very hardworking doctor, it's okay, one case went wrong in so many years. So we need to do that. So in these obstetric emergencies, what is recommended is that, suppose this amniotic fluid embolism happens within, before the woman is delivered, or if there's a cardiac arrest, within 5 minutes, there should be a capacity to deliver the baby. There should be resuscitative measures. CPR should be available. And so there are two ways that you can bypass this. Either you have an intensive care as a backup, or all obstetricians should take up at least a basic life support or critical care training, that you and your paramedic team should be aware of what to do in these kind of cases. Because are we ready for such resuscitation every time we deliver a woman? Perinatal awareness and preparedness is basic and advanced life support courses, skills and drills with all the staff, so that, because you will be dealing with the patient at that time, and suddenly when things are required, where the instruments are going to come from, where the monitors are going to get attached, your staff has to be ready for that. So we need a complete, skilled staff who will be able to do that. And these people are not available everywhere. You have to train your own staff and make them skilled. You can't ask for skilled staff and they won't come from anywhere. Your own staff, you have to train them. So even better if you have a critical care support team, because remember Murphy's Law and practice obstetrics now. Do not think that nothing will go wrong because I'm just a very good person. So the postpartum period is also known as the puerperium, and nowadays it's called the fourth trimester, because, after birth, that is the time when you have to take care of patients. And the American College says up to 12 weeks of delivery. We were used to saying 6 weeks of delivery, but the ACOG now says postpartum care has to extend up to 12 weeks after delivery. And since more than half of the deaths occur after birth, strengthening postpartum care should be a priority. So the World Health Organization has recommended 4 health contacts in the first 6 weeks after birth. And thereafter, there is a lot of thrust that is being given to postpartum care. So the other thing that one must be aware is postnatal rounds. After you've delivered the woman, if she collapses, of course, people will call you. But even if she does not collapse, there are some basic checklists which everybody should be checking in the postnatal rounds. Now, all of us, as we grow older and as we become more senior, we actually don't spend that much time bedside, because we are required at more, crucial junctures. So it is very important for people who are working in medical colleges. By default, you will have bright students assisting you. But for those who are working in regular settings where you have your nurses and all, make them aware that, this is the checklist you have to check every time when you go on a postnatal round. and at least they should, tick it off. So this is a mnemonic called bubblers: breast, uterus, bladder, bowel, lochia, episiotomy, emotional response, and the Homan sign. Then after pains, micturition, constipation, lactation, or vaginal discharge. Perinatal well-being also includes mental well-being, and this postpartum depression, postpartum mental disorders. I'm sure we'll remember that at one point when the confidential inquiry of maternal deaths revealed that just postpartum depression can be a very important reason for maternal mortality. That is when the people became so aware and so alert about this problem. Our women are not used to expressing these psychological problems, and we as a society also don't pay too much attention to somebody being sad. Arey, aise hi mood kharab hoga, something else. So now if you see on the television, you have so many advertisements, so many things making people aware about mental health and telling them how important it is not to miss those little signs of depression and anything that can lead to a bad outcome. And perinatal depression can be suicidal. They can harm themselves, they can harm the newborn baby, and they can really cause trouble. So unless we pay attention, we may miss that part. So taking care of that is also very important. And these are the potential life-threatening issues in the perinatal round. So headache, hypertension, seizures, hemorrhage, uterine inversion, dyspnea, chest pain, severe painful vulval edema, which may be part of the streptococcal infections. So these are things which all of us know that we have to pay attention, but this is just a reminder that do not forget these things, because over a period of time, we become a little casual in our approach to the postnatal rounds. Once the woman is delivered, we just think it's okay. See, for us, that might be the 500th delivery, but for that woman, this is the first delivery she's had, and she doesn't know what to do in the postnatal round. So every time we see, every time like a parrot, we have to remind her of all the postnatal events that have to be checked. Then comes the neonatal period. The thing is about the baby, we don't think that much after we've delivered, the Apgar score is good, and then you just forget about the baby. But what happens if you've delivered a baby, but after one day, suddenly the child is showing signs of cardiovascular collapse? The nurse comes and says, "Kuch to ho raha hai, madam. It's not, the baby is not really responding the way it should." Then what do we do? How many of you have the kind of backup that right now, the moment there is a red flag raised, a neonatologist will come and see that baby and tell us what's going wrong? So if the baby starts showing signs of impending collapse after one day, what can be the problems? The problems can be there may be a cardiac anomaly, and cardiac anomalies cannot always be diagnosed at the time of birth. Because when the neonatologist comes and the baby cries and gets a good Apgar score at 10 minutes, the neonatologist goes away. But how will you detect subtle cardiac abnormalities? Everyone may not have a murmur, and you may have small problems where the saturations are just around 70, 80, and then they start dipping after 24 hours because the circulation changes at that time. Any metabolic disorder where the baby has an inherent genetic problem and therefore has a problem when the normal metabolism takes over, and then after about a day or two, there are seizures, there is failure to thrive, there is excessive cry, and then the baby starts showing signs of collapse. Hypoglycemia itself can be a sign of collapse. Hemorrhage in the baby. Somewhere while delivering the baby, you might have held the abdomen and you might have ruptured some organ which you didn't know, and now it's presenting as a collapse. So all these things could be there in the baby. If there are signs of collapse, they need to be identified. And then how many times have we met patients who said something happened on day 3 and the baby died? We just write cot death or we write milk aspiration. But then when problems recur in the next pregnancy, then we realize that there must have been something different in that first death. Because I deal with this very often. The area where I practice, there is a lot of consanguinity. And about 10 years back, that used to be a standard practice. They used to go to one doctor, have a bad outcome. Then they used to go to another doctor who would do a cesarean section at 37 weeks, thinking that the first one was birth asphyxia. And then again, when the outcome recurred, then they would come back with cesarean sections with 2 babies having problems, and then realizing that this is not one of those birth-related issues, but it is an inherent genetic condition which is happening again and again. So if we are not aware of these things and we don't tell patients the warning signs,
बहुत हार्ड होता है ना, इसलिए तुम लोग अब भूख लग
if we don't tell them the warning signs of these problems, then we will never realize, and we might get um, blamed for the wrong reason. So it's an important thing for us to know that if there could be neonatal problems which are not because of us. Everything is not because of a wrong delivery. Everything is not because we waited too long. So as an obstetrician, please think, how confident are you to handle this situation? I mean, do you have an in-house neonatologist who will answer all your queries at all time? Dr. Neha probably will have that facility, but will everybody have that facility that the moment you think something is wrong, there will be a neonatologist to come in? Or if you want to send this baby to a neonatal care facility, because now till 24 hours she's admitted with you, and if the baby has collapsed, can you now send the baby to some neonatal care facility? One has to think of that, because when we set up a labor room, our entire concept is about the lighting and the care of the labor table, but are we paying enough attention to that? This was a case, we have had this case ourselves, and I'm telling you that these are the patients, they will present like that. Everything was good, but then when the baby showed signs of collapse, it was a partial anomalous pulmonary venous malformation. And that is not something which you can see very easily on the scan. So the first thing the parents will tell you, pehla to heart defect, the moment you say heart defect, their lids go off. Secondly, what did you do, madam? Wherever you sent, we got the scans done there. Why this defect was not detected? So if you see partial anomalous pulmonary venous connection, the pulmonary veins, instead of entering the left atrium, they're entering the right atrium because there is a connection behind the heart. And that cannot be detected on antenatal ultrasound. It's very difficult to detect it because you will just see the veins. You will see a vessel on top of it, or a chamber on top of it. Whether the veins are entering the vessel or they're just going behind the vessel, how will you tell on ultrasound? It's not possible, because these kind of diagrams we get only in textbooks where red is red and blue is blue. On actual ultrasound, everything is like black and white. So it's one of the things that we need to understand, that we should not feel let down that, oh, the doctor did not see it. There are some problems that we won't see. These are the basic things you see on a scan. You see 4-chamber view, outflow tracts, 3-vessel view. So antenatal ultrasound can detect about 80 to 90% maximum. If you use color Doppler, you use other things. But if you only use the basic views, which is the standard recommendation in anomaly scan guidelines, you will detect only 70 to 80% of the problems. So the rest of the problems which are missed are generally treatable, and that is why that's not such a big deal. But what you need is a high index of suspicion and a quick diagnosis. So the moment the baby has poor saturation, that baby, if it had been monitored with its saturations, then you would have actually picked it up before the collapse happened. But if the collapse happened, did you have the facility to send this baby to a center and get everything done? Because if everything is managed, at the end of the day, the patients will not feel so bad, and you will not feel so bad. But if everything is not managed, then it will lead to some kind of a problem, and that will be a sometimes lethal for both the baby as well as the doctor. So ultrasound cannot detect all abnormalities at any stage. Whether 20 weeks, 24 weeks, 40 weeks, 3D, 4D, whatever you do, all abnormalities cannot be detected by antenatal ultrasound. And once you say that, please be ready for some anomaly after the baby is born. It doesn't mean everybody will have the anomaly, but there could be an imperforatanus, there could be some kind of I mean, and especially these this is a list of problems, that you may not see in the congenital biliary atresia. There's a very poor detection of that in the antenatal ultrasound. Large bowel, small bowel obstructions, skin-based genetic conditions, ichthyosis. The babies with ichthyosis, they look so different. But if you have not actually suspected it, it's very difficult to see it on ultrasound. The baby is born with all those skin lesions. The parents feel very let down, but you need to tell them that this is so. That process has to start right from the beginning. Even when the normal person is doing an anomaly scan, they should tell that this is our limitation. Up to this we can see, beyond this we can't, so that they are also mentally ready. આજકાલ we start putting hoardings, 3D hai, 4D hai, we do this, we do that. Patients' expectations start rising beyond the realistic levels. So it has to be a group practice from that level where we tell them that there are limitations of antenatal ultrasound. And simple problems like metabolic syndromes, hearing defects, partial agenesis of corpus callosum, polydactyly, syndactyly. Now again, counting of fingers is not part of any antenatal scan. It is not given in any guideline because it doesn't have a bearing. What will you do if you see 6 fingers? But suppose the baby is born and it has 6 fingers, suddenly there will be a uproar. So hypospadias, ambiguous genitalia. You tell us in a country which does not allow us to look at the genitalia, how will we diagnose ambiguous genitalia? And what is ambiguity? Ambiguity is non-conformation to established chromosomal gender. So sometimes it might just look like a female and you might think it's a normal female, and only when you do a karyotype you come to know that it is an XY with a female genitalia. So those are some of these complications are expected despite the best care that you can provide in antenatal period, not because you are lacking in something, but because the whole system does not support some diagnosis. So remember that there is definite checklist for all diagnosis, and this I always like to bring it to your notice that, you know, this is the detection rate of fetal anomaly scan given in the NHS, the UK National Health Service patient information leaflet. Can you see there, the detection rate of anencephaly is claimed to be 98%, not 100%. So anencephaly is something you will think, oh, in that age when I'm talking of those venous connections in the heart, why can't I see anencephaly? Well, sometimes you can, but sometimes if there's a large fibroid in the lower segment of the uterus and somebody is seeing it's calcified, he might still miss anencephaly. So, you know, you go to that extent to protect your, colleagues and tell them that some things are not seen on the antenatal scan, and therefore they should have realistic expectations. So patient information leaflets at every stage in antenatal care and perinatal care helps. This is, of course, thing. So there are lines which you need to draw and understand that what anomalies can be detected on ultrasound, what cannot be. So what is very important is that have you advised the scans to be done at the right time, and have those scans been done and detected properly? That is your responsibility as an obstetrician. If thereafter there has been a misdiagnosis or there has been something missing there, then that's something which you cannot come up, but be sure that whatever you've done correctly, and always team up with a person who scans and does things properly so that you have minimum of these problems. Suppose there is an anomaly detected and you have to take care of that, then there is a multidisciplinary team approach that you should have, wherein you bring in the specialist. Suppose there's a heart defect which you have diagnosed on anomaly scan, and now they want to continue pregnancy with that heart defect. Then bring in the pediatric cardiologist, the neonatologist, everybody, continue the pregnancy in a definite way, deliver at a time when all the specialists are available, and hand over the baby to the neonatal team for further care. And that is happening more and more now. Cleft lip palate, exomphalos, club foot, whatever can be corrected, these problems are now being continued, not terminated at all time. All we need is a multidisciplinary team which works very nicely in conjunction with each other. Now, whenever a newborn baby is delivered, please remember this is the minimum checklist you should do for them. Immediately Apgar, one thorough external physical assessment, orogastric continuity check, saturations, temperature, and sugar monitoring. Lot of our women do not breastfeed immediately for various reasons. Please encourage them to breastfeed as soon as possible. Lot of people do not give the baby anything for 1 or 2 days thinking that the baby will have some infection. That leads to hypoglycemia. And hypoglycemia in the newborn period can have severe mental retardation as a, follow-up. I have seen children with global developmental delay where the MRI changes are clearly saying that there was no birth asphyxia, but there was neonatal hypoglycemia. And that is something completely preventable, and we should do that. Any red flag signs, early jaundice, seizure, cyanosis, any abnormal facies that you notice, excessive cry, inability to feed, please get your neonatologist to see this baby, make a plan for the baby before you discharge them from your hospital. The neonatal mortality statistics, if you look at them, around 75% of the newborn deaths can be prevented with known effective healthcare measures during the first week of life. So all it takes is awareness, and that is what I'm trying to propagate here, that please do not forget that any baby you deliver might have any problem. So if you see one red flag, please alert the neonatologist and get that. Labor, birth, and immediate postnatal period are the most critical times for newborn and maternal survival. And therefore, if we want to end preventable stillbirths, we have to improve our perinatal mortality statistics. We need to be aware of these problems in the perinatal, and these are all preventable deaths. And now these statistics have become an indicator of our healthcare levels. So tomorrow, if somebody asks you that you as a society in Ratlam, how are you performing as an obstetric or perinatal caregivers? What is your mortality statistics? What is your morbidity statistics? So if that is coming down, then effectively the care that you are giving to your patients is coming down. And if we start doing at every society level, I'm sure it will reflect in our national statistics. Already our maternal mortality is getting better. That's just because of our awareness and our updating ourselves regularly. So in the entire perinatal period also, we should take care of this, because the birth is the greatest time. It's a time of greatest risk of death and disability. And if you try and invest in this time, your returns will be much better. So if you look at perinatal mortality in preterm birth, intrapartum complications and neonatal infections, these are the three major killers of babies today, and all three can be optimized if we are aware of the risk factors and we take adequate precautions, because neonatal infections is completely preventable. Intrapartum complications, you may prevent some, you may not be able to prevent some, but you can optimally manage them if you start, you are aware of what it is. And preterm birth, of course, we have that debate all the time, whether we can prevent or not prevent. Being aware and delivering a baby in the optimal circumstances is the best thing in a preterm setup. Now, these we have already spoken about. This is the status in India. We have a wide variety of newborn care. And that is what hurts me sometimes in the newspapers. You send off these 500 grammars, 300 grammars we have saved. For that one baby, you lose care for so many, 1.5 kg babies in normal NICUs. So I think somewhere we have to be rational and focus on developing a standard newborn facility in every part of the country. Because even one baby who requires newborn care in a place like Ratlam should not be deprived of it because you don't have that facility there. So whoever has it, however you can access it, please make an effort to, approach these services and develop it. If you don't like that place, you develop your own services, but do not give that service to your patient, because these kind of things can be life-saving to the baby, and they have a very, very strong thing. Things like kangaroo mother care, I'm sure all of you are aware of, but in preterm babies, this is a very low-cost intervention which can, really provide a lot of relief to both the mother and the baby, because it's just skin-to-skin contact. But doing it in a correct way needs some training, and these trainings are available. I'm sure the WHO packs, they can do this training. Even the Indian Academy of Pediatrics, they are happy to provide such kind of training. In fact, with Perinatology Committee, we have a joint workshop with in Indian Academy of Pediatrics, and they will be very happy to provide this training if you really want that to be done. So potential areas of dilemma, again, vaginal versus cesarean section. When I talk of so many perinatal problems, you will think, oh my God, if to prevent birth asphyxia, let's do more of cesarean sections. Now, the thing there is no ideal, you cannot have one ideal recommended rate of cesarean section. I think everybody has to believe in our obstetric decisions, and we have to make our decisions very judiciously. We will only deliver in a particular way if it is safe for the mother and the baby. And whatever is the optimal method of delivery should be the obstetrician's choice. And I don't think anybody should be there to, like bully us that you should do this or you should do that. Because if you don't trust us, then don't get care by us, because that's it. So the decision for mode of delivery has to be taken by the perinatal team in the best interest of the mother and baby. And the circumstances of delivery vary in each individual case. If you read the theory, even for fetal anomalies, nothing is an absolute indication for cesarean section. But then, if you are delivering somebody, you've continued to take that baby with a large exomphalos or a large neural tube defect till 9 months. You don't want to deliver 2 in the night when there's nobody there to handle the baby. So you may want to deliver that baby at a time when all the facilities are available. You need an exit procedure. You need a senior neonatologist. You need a senior anesthetist. So you might want to do a cesarean section in that case, and that might be what the parents want. So these things we have to be aware of, and we also have to make our standpoint pretty clear. And all this will eventually help in improving our newborn statistics. So whatever these perinatal red flags are, they are points of perinatal awareness, where if we take one step the right time, then a stitch in time saves 9. That's exactly what will happen to us. We will take our precautions at a time when we really don't have that many complications, and eventually we will have a safe practice less number of complications. It's good to not require your emergency team. It's good to not require your resuscitation team, but it is very important to have it. So just like we lock our houses, isn't it? It's not like every day we are expecting a burglary, but we always lock it because we know that once we've locked it, we have taken our safety measures. People will always ask us, if you do all this, can you guarantee that everything will be fine? So the only guarantee that you can give as a perinatal caregiver is we cannot cure everything, but we can definitely care for everything. And that should be our motto when we take care of all our cases. Thank you very much for a very patient hearing.
Thank you, ma'am. I request our chairperson, Dr. Anupama ma'am, to conclude the talk, ma'am.
Yes. Thank you, Dr. Chinmay, for your excellent. Am I audible?
Yes,
Yes,
yes.
Am I
now you're not audible, ma'am.
audible? Neha?
Ji, ma'am.
Neha, can you hear?
Yes, ma'am, I can hear you, but the voice is breaking in between. Probably there's some network issue.
Hello? So, thank you, Dr. Chinmay. Okay, now?
Yes, yes.
Yes. So thank you, Dr. Chinmay, for the excellent presentation, especially the difficult scenarios which you had discussed. And as you have rightly said about the Murphy's Law, that nothing is easy as it looks. Anything can go wrong, and the concept of multimodal awareness and the very many red flags in the perinatal period, both maternal as well as neonatal, which have to be identified. The need for intensive care backup, for the whole team to be trained by basic and advanced life support, and the importance of postpartum care till 12 weeks. These were a few points which were very important and which you have so nicely presented. Thank you.
Thank you, ma'am.
Thank you, Anupama ma'am. Chinmay ma'am, it was really a worth listening topic. Actually, when Manisha ma'am me about the topic that we are going to have this webinar, I was like, acha, perinatal, okay, theek hai. But ma'am, I really would like to say every word was worth listening to, and those who have missed it have really missed something. But they are at a big loss. People have started asking for the recordings also.
No, I think we should do one workshop in your society where I'll try and organize a live workshop, because
Ma'am,
the
our pleasure, ma'am.
Definitely, madam.
IAP and Neonatology Forum, they are actually very willing to come and do that, because what I felt is, even if we try and improve our obstetric care or get adult critical care, the newborn part really is a challenge. And having an in-house neonatologist always is not possible. So even in newborn units also, some of the nurses are the ones who actually take care of the intubations and, the immediate care. So over a period of time, we have to learn to work with our paramedics and make them, competent enough to help us in these difficult situations. So if you all are willing, we'll do one workshop there.
Definitely, madam.
IAP has a program where they have called it caring at both ends of the cord. So I thought it was a very beautifully named program. So caring at both ends of the cord. So there is a lot of newborn issues there, as well as maternal issues. And we should do that kind of, because everybody there is no shying away from the fact that, we can face any of these problems at any time.
Ma'am, we would also like to have a workshop on basic life support.
Yes.
For obstetricians. Ma'am, if you could please arrange your...
No, we can do that. I have a very good intensive care team that we have here. And I think we can merge everything together and do that. Let's fix a date or something and do it in Ratlam.
Your way of talking is very good, Dr. Chinmay.
Thank you.
Your way of talking is very good.
Thank you so much.
You explained very nicely, madam.
Madam, one of my patient is having hearing defect, antenatal period. She is about 14 weeks at present. and their relative want for the confirmation for that baby. Now, second, anti-scan cannot be. Of course, it will not help, but it could not done. She didn't came in time. Now I advise for targeted and particle marker, but how I can help her?
Ma'am, she herself needs to get evaluated, because what is the type of hearing defect that she has? Suppose her hearing defect is because of a mechanical damage of her hearing apparatus, then that is something which won't, transfer to her baby. If she had it because of an infection, like CMV infection is one of the leading causes of sensory neural hearing deafness. So suppose she herself had it post-infection, then she won't transmit it to her baby. The only way that a maternal hearing defect can get transmitted is if it is a genetic origin. So there are some genes like the connexin gene, which they can check in the mother. So the mother needs to be evaluated by a good ENT and a specialist and a geneticist to find out what is the cause of her hearing loss. If the cause is genetic, and if it is a like autosomal dominant kind of condition, then she has a high chance of passing it to her child. If suppose it's an autosomal recessive condition and she is not married to another person who is a carrier of the same condition, then the child won't have a problem.
Husband is normal, but
Exactly. But they need to know, because if suppose it is an autosomal recessive genetic disorder and she definitely has both the abnormal genes, and if husband is also a carrier, then there's a 50% chance that the children might get a recessive disorder. If it is an autosomal dominant problem, then also there's a 50% chance that all the children, 50% of them can get a problem. But what is the most important thing is what exactly is the cause of her. So that needs to be established first.
thank you. Thank you, madam.
Thank you,
And
ma'am.
one more question. Actually, I just wanted to ask, how often should we be doing the screening 2D echo for the pregnant ladies? Like, that is what I have been doing for all my patients, because I have an in-house intensive care unit, like intensivist at my place. So I asked my husband to keep doing a screening test, because we had two untowards delivery patients.
See,
So I just want.
let me tell you one thing. Huh? Now, what she said, I have an in-house intensive care team, hence I do 2D echo for
Yeah,
everybody.
yeah.
Hai na? But actually, if she doesn't do also, it doesn't matter, because if she has a problem, she has an in-house intensive care team. So it's a good thing that you do it, but you are not the person who will actually suffer from not doing a 2D echo. The thing about the other people is those who, now that's a difficult thing to manage, because Indian government or Indian bodies cannot make guidelines for providing 2D echo to all pregnant women, because we won't have the facility. If the government makes a guideline like that, it's the government's responsibility to make that facility available everywhere. And currently, we know with our population, it is not possible to provide these kind of services to everybody. So I think it's a judgment call we have to make. So when you look at your practice, what kind of women do you see? So suppose I see most of the women who are fertility treated post IVF, and they're all like 30 and above, then maybe we do that because we deal with the high risk population. Otherwise, you just keep a sort of a safety net for your patients and see that if these factors are there, then I will get a 2D echo done for this patient. If she doesn't have any of these factors, then I'll keep a high index of suspicion and deal with it when the problem comes. But definitely, breathlessness in the perinatal period has to be, sorted out. So if you don't have an intensive care team, please be more proactive in getting the 2D echo done.
Ma'am, what should be the time of 2D echo? Actually, I keep doing
Very
it around 32 weeks.
Yeah, it's a very difficult question to answer, because 32 weeks is a reasonable time, because 32 to 34 weeks is the time of maximum hemodilution. So the maximum pressure that comes onto the system is around that time. So I think that's a reasonable time to do it. And if there is any symptom, I think you can do a routine one at
Actually,
that
we
time.
had multiple patients who were asymptomatic, but because of regularly doing 2D echo, we got to diagnose them in time, and we managed them. Like patient had a mitral valve stenosis, a tight mitral valve stenosis, and would have definitely had problem during the labor. And she was totally asymptomatic, but because we did a screening 2D echo at 32 weeks, we got to know it. Balloon valvotomy was done, and she delivered very well.
No, that's what I'm saying, because in places where the antenatal care or previous medical care has been poor, these things would remain undiagnosed things. So at least if you can't do a 2D echo also, at least one physician checkup, at least, auscultation of the heart murmurs. They say even we can do it, but honestly, I can't put my hand on my heart and say that I'll pick up all the murmurs if I do auscultation for all my patients. It's not all that easy. So if there is a physician available, at least all of us work with anesthetists, right? So just like we do a pre-anesthetic checkup, maybe around 12 weeks or 13 weeks, just get a proper checkup done by anybody. See, we can't have these guidelines in a very grand way, but we can make our own solutions based on our situation. So if you don't have anybody also, you will have an anesthetist. No, without an anesthetist, I don't think any obstetrician practices. So you can just tell the anesthetist that on such and such date, please come and just do a screening checkup for all my patients who are antenatal. So get it done around 12, 13 weeks, so that at least you are sure that you're not dealing with anybody with anything serious. And even history taking and all, the way they take that history, that is really, really very, very like revealing.
Unbiased, huh?
The way we take our history, we don't pay attention to certain things. So when I work with physicians and anesthetists, I realize that their ability to pick up, minor issues is much higher. So just one checkup with them, it's less stress on us, because at least you got it checked. Later on, if she has a problem because of a de novo issue that comes later, at least you can tell that, look, I made my effort and I get everybody tested. Like you do your 2D echoes at 32 weeks. It may sound superfluous to some people, but whatever makes you safe. If you are able to afford it, please do it.
Yes, ma'am. Getting a physician checkup done sounds a good idea.
Because if you see the RCOG guidelines, they have said that, the handheld note should be there. See, in RCOG, what they used to do is they do a confidential inquiry of maternal deaths. They are able to do all the maternal deaths because they are a small country, few number of patients, and they have a good recording system of all medical events. So when cardiac disease became one of the largest killers of maternal population, they instituted this, that every pregnant woman should have at least one physician checkup by 12 weeks of pregnancy, so that pre-existing cardiac disease can be ruled out. So we have two major problems, isn't it? We have rheumatic heart disease, and we have because congenital heart disease surviving to that extent without being checked is not so common. But the ones which are undetected are rheumatic heart disease and peripartum cardiomyopathy. So for rheumatic heart disease, at least that mitral stenosis murmur they will hear at 12 weeks and at least alert the patient. Because what happens if the patient does not have any red flag? Patient thinks she's completely normal. And then when things go wrong, they start blaming everything to your method of management, and you start worrying what something you must have done. That is not fair on obstetricians.
Madam, but we cannot suspect peripartum cardiomyopathy before in antenatal period also.
You cannot, but somewhere down the line, we have to now start suspecting also and making people aware. So even the patients also know, while you are counseling, see our antenatal counselings, again, I'll quote the RCOG because I like the way they classify things. Every gestational, every antenatal checkup has been given a purpose. So when you meet a woman at 12 weeks, you talk about this. When you meet at 6 weeks, you talk about screening. When you meet at 12 weeks, you talk about the anomaly scan. When you meet at 20 weeks, you talk about, her future immunizations and growth assessment and things like preeclampsia signs. So similarly, when we meet them around 30, 32 weeks, I think we need to tell them that pregnancy is one of those conditions where there is a risk on your general system also. So if you feel breathlessness, if you feel exaggerated symptoms, it'll be good if you tell us. If you have a if you have a physician checkup, that might be good for you. Let us offer it. We take too many decisions for our patients. We decide it's बहुत costly hai, they can't do it. The same about screening, madam. We decide Down syndrome screening is costly, my patient can't do it. But if the patient cannot afford Down syndrome screening, the patient cannot afford a baby with Down syndrome also. So let us give them the choices. If we can make everything available in our center, excellent. But suppose you say that there is some center where you can just go and get a heart checkup done. Give them the choice that, this is available. If you do it, I'm also safe, you also safe, because we are delivering here. We don't have a backup of cardiology right here. it may be a good idea for you to get yourself sorted out that you are not a particularly high risk problem. And for emergencies, you make your own backups, talk to your friends, keep them in good relations with you so that they will come in case you have an emergency. Because in places like Hyderabad and all, we don't worry that much in the sense that, God forbid, if there is an emergency, there are many places where you can shift a patient safely. I can even call for a fully equipped ambulance, which will take my patient to a fully equipped place with a fully, covered doctor suffering that. But it may not be possible in places like yours. And when something happens in the highway, that is something which, everybody will blow out of proportion. And for that 27 years of good practice that you have done, that it just takes that one case to, you could not get a newspaper headline for the webinars you did, for everything you did, but one thing goes wrong and you will be all over the news the next. So
Hello.
I think we need to be a little careful and,
Usually the patients of cardiomyopathy, I think it is not a very sudden thing. It is almost a gradual thing. And usually they first present as tachycardia. If we have excluded all the other causes of tachycardia like anemia, thyrotoxicosis and all the other, the thing should click to our mind that she might later on have cardiomyopathy, and that particular patient should be thoroughly investigated.
that's what, ma'am.
Yeah,
Somewhere
that
we
is
should
my
have
one point. And another, what I wanted to say just in the beginning, you said about amniotic fluid embolism. That is really a nightmare for all of us. And we just pray that that should not happen to us. But still, it does happen. It does happen. And what I think that on a national level, there should be some workshops like that, where endotracheal intubation of the adults and as well as of the neonates should be taught to all the obstetricians.
No, absolutely.
When
That is what I'm
when
trying
it
to say.
happens suddenly, even if we will call a physician, or even if we have a physician in our own nursing home, that fellow will come at least 2 minutes to come. And those 2 minutes are very precious. In those 2 minutes, if we ourselves intubate the patient and just connect it to the boil equipment and start doing at least IPPR, we'll save those very 2 precious minutes.
No, absolutely.
I
I
think
think
that,
that
and
is
even it is same for the neonate also, because by the time we will call a neonatologist, it will take at least 10 minutes. So those 10 minutes are very precious. So if at least we intubate and start IPPR, or we connect it to the embus and start respiration, that is quite helpful, I think.
No, absolutely, ma'am. And that is the point of
And
this.
even,
So
even I think there is a, even if there is no such program, all the obstetricians, we practice with our anesthetists, we can request the anesthetist to teach us endotracheal intubation. Even in one
very,
or
very valid point, ma'am.
also,
Because
if
we
they
need,
teach us endotracheal intubation, it is very helpful.
and
Not
that crash
only,
trolley and just being aware of the crash
yeah,
trolley, knowing what to
yeah.
give when.
At least we have endotracheal intubation, endotracheal tube and embus bag in our labor room also. So we can just intubate and connect it to embus bag by the time somebody comes for help, because that we can do it. So
No,
we
you're
should
very
be
right, and that is
confident
exactly
in
what I'm
doing in
saying.
that. Yeah.
We should become, like some kind of checklist you should have, and you should feel that I am like perinatal equipped. I will take care of my perinatal cases
Because in
without
our
problems.
time, I tell you, we used to learn doing lumbar puncture also, endotracheal intubation also, everything we used to learn. But now the things have changed with super speciality and everything. But if still somebody is practicing obstetric, I think that should be there.
Either they should have a person who can do it, or they should learn it themselves and teach their paramedics.
Because even if you have a person who can do it, even if your husband is anesthetist, he will come at least 2 to 3 minutes to come. And those 2 to 3 minutes are very precious.
Agreed. Okay, ma'am.
Great. Thank you for the lovely talk.
Thank you so much.
Thank you, madam, for such a nice discussion also.
And your talk was very informative. Each and every word was very precious, very helpful
Yes.
in our practical life.
Thank you so much,
It was
ma'am.
very good. Thank you.
I request everyone to join madam's second session on 2nd of June. She will be speaking on Doppler in obstetrics,
Yeah, definitely.
7
Definitely.
p.m. Yeah.
Okay,
Thank
ma'am.
you, madam.
Thank you so much.
Thank you,
Thank
ma'am.
you.
Thank
See
you,
you
ma'am.
once
Thank
Thank
you.
you, everyone.
I
Thank
think
you.
Leela Joshi ma'am has just joined. So namaste,
Okay, good
ma'am.
evening, madam.
I'm in a webinar. I'll call back.
That
Okay.
my ma'am is getting a call, I think.
Yeah. Bye bye.
Thank you, ma'am. Good night, ma'am. Thank you for
Bye bye.
the
Thank you, ma'am.
Thank you. Thank you